I'm glad you're joining us today for this important conversation on planning for the end in caregiving. Pam and I will monitor the chat for comments and questions, which we'll discuss at the end of the presentation. At AARP, supporting caregivers is one of our top priorities. We know caregiving is both meaningful and challenging. Today's presentation will help us plan ahead to make informed decisions that respect the wishes of those we care for. Our speaker, Jane Barton, will guide us through the kinds of decisions that shape everyone's final chapter. Decisions that may be made months or even years in advance. Jane will share her background with us during the presentation. Please join me in welcoming Jane.
Thank you, Alan. Let me share my screen with everybody, and away we will go. So good morning, one and all. I am delighted to share a little bit of time with you today, and I certainly want to extend my heartfelt thanks to AARP Colorado. I've been blessed with a collaborative relationship with this state office for many years, and I thoroughly enjoy tag teaming with Alan and Pam and Jessica and many other staff members to create programs, hopefully, that will be beneficial, maybe inspiring, and somewhat provocative to get you to think. And hopefully, as a consequence of this program today, will motivate you to do a bit of planning. Now, for those of you that are unfamiliar with me, just a quick little thumbnail sketch. I think it's relevant for you to understand who I am and what I'm about, because I'm going to share some stories with you today as well. So obviously, my name is Jane Barton. My company is Cardinal LLC, and I serve as an educational consultant, which means I get to do what I love each and every day. I serve as a speaker, a writer, and/or a listener, and I focus on the topics that I'm passionate about: aging, end-of-life care, and caregiving. I have a background in hospice and palliative care. I served as a chaplain for a short period of time before assuming the directorship of education for a palliative care institute here in Denver, Colorado. And I did that for about 6 years before I launched my own company. Before that, I was in finance for about 4 years, and my first career was that of a petroleum geologist. I worked in the oil patch. So a rather quirky professional career, but it has served me well. But of greater relevance to what I do today, my motivation for speaking about some tough topics has to do with my personal story. I was called to care when I was 15 years of age. My mom was diagnosed with terminal breast cancer. And that has proven to be the formative event of my life because I learned so much in that process. And my greatest learning is this: knowledge is power. And without it, life can be pretty darn scary. So whenever I speak, whenever I write today, I think about you, the audience, and what information and resources could be potentially beneficial to you, so that when you're challenged by life, you have been, you are, and you will be, you can gather that information and you can make informed decisions instead of merely reacting out of fear, because that never serves us well. And so that's my mission today, as I encourage you to plan with the end in mind. What could possibly go wrong? Now, this is a very countercultural conversation. I'll be honest with you. I'm known for this. I broach the hard topics and hopefully afford you an entry point that will allow you to speak of this. We are going to contemplate the reality of mortality. We're going to recognize our finitude. And we will also appreciate the fact that we just trust the process if we hope for the best. If we think the best care possible will be offered to us, we are ill-informed about that. Our trust is misplaced. We have to have some skin in the game. This is our life. We need to plan intentionally to make sure that our preferences and our wishes have a high probability of becoming our reality. So today, if you are a care provider, if you are a care recipient, if you are an interested community member or professional, this message is for you. Because again, knowledge is power, and proaction beats reaction every time. So let's consider what we're going to chat about today. First, we're going to lay a foundation of understanding predicated on aging today. What are we hoping for? What are our goals and objectives? Then we'll contemplate that when things go amiss, we will all be challenged in some way, shape, or form. When we have a medical turning point in our lived experience for ourselves or others, we need to recognize the complexity of care, just how daunting that challenge can be, and also how does our healthcare system today serve us? Does it serve us well? That's an important thing to recognize. We'll contemplate some unexpected twists and turns specific to the end of life. I'll share with you some viable, valuable resources in the medical profession. And then we'll conclude by reinforcing this idea that we need to be proactive about creating an exit strategy so that we can live well and also end well. So let's begin by thinking about aging today. What's the goal? What are you thinking about as you contemplate your future? Are you focused specifically on the numbers, how long you will live, so the quantity of your life? Or are you more concerned about the quality? Well, we define quality as far as acceptable in our own unique way. And I know there are some of you listening to me saying, well, I want both and. I want to live long and I want to live well. I get it. I'm right there with you. But the predominant focal point in our country, at least, and I'm speaking specifically about the United States, up until the last 5 to 10 years, we've typically focused on lifespan, which is the number of years someone lives from birth until death. So quantity. But if you read anything about longevity in the journals today, you cruise through your internet feeds, you'll recognize this term health span. And this is a different focal point. And it's all about the number of years someone is healthy without chronic and debilitating disease. So during this time of life, we can experience an extraordinary quality of life. We are vital and vibrant physiologically and cognitively. Now, you can consider the relationship between these two concepts in this way. We enjoy our health span up until the moment in time in which we don't. When we have a diagnosis or perhaps an accident that results in a chronic disability. Now, at that point, that's when we fall into this gap. And this gap is a time in which we as an individual are trying to learn how to live with a disease process or a disability. It's also the time in which our family members are scurrying around trying to figure out how to care for us. So, this is the time of caregiving and care receiving. And statistically, this gap is 10 years in length, a considerable amount of time up until we reach the conclusion of our lived experience. So, what are we focused on today? Well, researchers, clinicians, and certainly community members, we want to extend that health span for as long as possible to enjoy the highest quality of life, and we narrow the gap between health span and lifespan. Now, there is a center of research, the Stanford Center on Longevity, that is focused on this narrowing. They published a document in 2022 entitled The New Map of Life. And they said bringing health and lifespans into sync presents one of the greatest challenges and the most exciting opportunities we face in the era of longevity. But it's challenging, and there's so many factors that dial into our ability to narrow the gap between health and lifespan. And part of that is the nature of our aging process in this day and time. It's very different than comparing it to our lived experience in the early 1900s. And because of those differences, today, many people fear aging because it's a daunting journey. And sometimes we feel it's just this uphill climb. It's not an easy trek, not only physically, but cognitively, spiritually, financially, and psychosocially. Aging is very different today, again, than 100 years ago. And one of the big differences is the journey is much longer. So consider life expectancies today. We'll look at some data from the CDC. This goes up until 2021, and you'll notice the downtick due to COVID. But compare it to the early 1900s, where we were expected to live to the ripe old age of 47. And now women are expected to live until their early 80s, men until their mid to late 70s. Sorry about that, guys, but that's the biological reality. And the latest data indicates that we've reversed this trend after COVID, and we're starting to gain some of that ground back. In fact, according to Laura Carstensen, who is the executive director, she leads the Stanford Center on Longevity. She anticipates people living to 100 as a norm in the United States in the foreseeable future. So we're making strides in extending our longevity. So living longer, that's great news. But there's a flip side to this. We encounter different challenges along the way than those who lived in the early 1900s. And one of the big challenges is chronic disease. This is the big game changer for all of us, whether we are the care recipient or the caregiver. Consider the data offered by the National Council on Aging published in 2022. For persons 65 years of age and older, 95% of us have one chronic condition, and 80% of us have two or more chronic conditions. And every decade you live beyond 65, statistically, you are at risk for being diagnosed with another chronic condition. So obviously, this will shorten your life, probably, and it will definitely compromise the quality of your life. Ira Byock talks about the implications of chronic disease. You may be familiar with this physician. He worked in hospice for decades, and he is a champion and an advocate for the best care possible, specifically at the end of life. If you ever have the opportunity to listen to a presentation, to read some of his materials, do not miss that. He is a gentle man, and he strives to serve elders in our community and families that are confronting the very frightening time of end-of-life care. He notes that we are the benefactors and victims of scientific success. Serious chronic illness is an invention of the late 20th century. So how long we live, and also how well we live, is very different than generations before. So keep in mind that when diagnosed with a chronic disease, that is a very personal experience for a patient, but it's not private because there's a ripple effect throughout the family system. The people that we will count on that will provide the care that we require as that disease progresses. And that can be for an extended period of time. So once diagnosed, the wheels don't totally fall off, but there is this gradual progression and decline physiologically and cognitively. And in like fashion, as an individual declines, there is an ever-increasing need for care. So life changes for everyone concerned. So in this gap between health span and lifespan, what are the potential challenges we need to anticipate, that we need to envision, and some of the choices we may have to make that could impact and shape the ending of our journey? Well, certainly the complexity of care is something we have to be prepared for. And it doesn't mean that we have to be a degreed physician. Most of us are not clinicians. We're just doing the best that we can. But our healthcare system has offloaded a lot of responsibilities of care onto the family. That's a huge level of burden. So to give you an example, when I was caring for my mom when I was a teenager, I recall some of the procedures she went through that resulted in a stay in the hospital for 10, maybe 12 days. Those same exact procedures today are outpatient surgeries. And so families in less than 6 to 8 hours are now confronted by this reality that, oh my gosh, look at all these things I'm supposed to be doing. I have no idea how to do it. I've not been prepared. I haven't been well trained. And that's why there's a lot of anxiety and fear in the trenches of caregiving. There's also the duration of care. What can we expect in the gap? How long will this experience last? Well, on average, 4.5 years. This is not a mere inconvenience for families. This is a life-changing event for all concerned. There's also the intensity of care. Again, many of these diagnoses, as they progress, there are so many things that must be done. And sometimes that includes hands-on care in the home, much of which we feel ill-prepared and ill-equipped to do. And we desperately don't want to hurt the person that we're caring for. There are things like the day-to-day meal preparation, maybe some dietary requirements predicated on the diagnosis. We have to abide by that. And then there's the big stressor of med management. Most chronic conditions have a myriad of prescriptions that are related to that. And I don't know about you, but I've been in the role of caregiving and I get a little tired, and sometimes my memory doesn't serve me well. So I remember numerous times with the variety of family members I've cared for over the years, I've thought, wow, did I give Dad his medication this morning? Did I remember to do that? Was he supposed to eat with it or not? And so you start doubting yourself, and then the anxiety starts to ramp up. So that's why many of us figure out how to remember. So we have the pill holders. We have a personal digital assistant that has an alarm on it. We set an alarm on our watch or on our phone. I'm kind of a pen and paper kind of gal. So I have spreadsheets all over the house when I'm caregiving, and I can check things off to make sure that I remember what I've done and what needs to be done. Then we have the challenge of navigating the healthcare system. And we're going to talk here shortly why that is so difficult. But with siloed systems and specialists of all kinds scattered throughout different locations, oftentimes care is not well coordinated. And that coordination, that's another job that family caregivers and patients are required to do. You have to be your own best advocate if you are to receive the best care possible. Then we have medical and legal concerns. Typically, people, when they have a diagnosis, all of a sudden awaken to the fact that, wow, I need to get my advanced directives in place. I need to articulate my preferences related to healthcare and make sure I have a family that will support and advocate for that. Add to that my financial affairs. Do I have a last will and testament in place? Does it need to be updated? Again, another thing we have to add to that to-do list. And certainly make sure you have designated a surrogate decision maker. This is part of your advanced directives. Who will serve when you are not conscious or not capable of advocating for yourself? This is the person you are literally trusting with your life. And that comes to bear for end-of-life preferences. This individual hopefully will advocate and pave the way to the ending that you imagined and that you preferred. Another very difficult challenge in the gap between health and lifespan is dealing with incessant change. Now, I know the reality is that the only constant in life is change. Has been, will be, this is the nature of aging. But when you have a disease process that is progressing, it becomes very frustrating, actually exhausting, because just when you think you have everything well in hand, you have this lovely balanced existence again, something happens that destroys that equilibrium. And so you feel like you're starting from square one again. So we could probably add to that list of challenges in the gap, but I think you get the message. countless opportunities for derailment of the plan that you have in mind that leads to an ending that aligns with your values, your priorities, and your goals. So the underlying message is this: we have to be vigilant, we have to be attentive, and we have to be proactive to make sure that we are headed toward the ending that we choose. Now, in contemplating this, we also need to recognize the country in which we live and the healthcare system in which we will interact after being diagnosed with a serious condition. This is the stage upon which we age. And will we age well in light of that? Well, I'm not here to slam our healthcare system. I'm here to enlighten you to some of the potential challenges. And the first question is to wonder, does our healthcare system, does it actually serve us well? And is it a nurturing environment? Will it be life-giving in some ways? Well, let's answer that by looking at the nature and the landscape of our healthcare system today. First and foremost, we need to recognize the system leans toward aggressive interventions. That is the acute care model that all of our doctors have been taught and weaned on in medical school. And I'm not saying that's bad. The focal point has been you are deemed to cure whatever is going on for your patient. And oftentimes that requires aggressive interventions. But on the flip side of that, it's also recognized those same interventions often become the source of suffering, exacerbating suffering because of side effects. Now, that wasn't the intention, but that becomes the reality for the patient. Eric Cassell talked about this many years ago in a book he published in 1985 entitled The Nature of Suffering. He himself was a practicing physician, and he was morally distressed because he realized what he recommended to his clients oftentimes reduced the quality of their life. Now, one of the reasons aggressive intervention is the go-to for doctors is they're trained to do. They are trained to cure. And that's good at some points along the journey of aging. But sometimes doing is not always wise. And that is particularly true when the end is near. The viability and the likelihood of benefit in the latter part of life is less than if we are 35 years of age and perhaps we were in a car accident. The viability of some of those interventions is wonderful. We have the likelihood of turning this situation around. Not so much when we're compromised by the frailties of aging or we're dealing with perhaps 2 or 3 chronic conditions. Another thing that we need to be attentive to, and perhaps you've actually probably experienced this, feeling as if you're not being seen or heard as a person, but instead your clinicians are just focused on curing and treating a disease. This is dehumanizing. I am not my disease. I am a person. Hence the importance of person-centered care models in our healthcare system today. Now, this tendency was recognized by a doctor many years ago in the early 1900s, a gentleman by the name of Dr. Francis Peabody. And in a publication in JAMA, he noted that the secret of the care of the patient is in caring for the patient. He said, yes, we as physicians, we need to focus on curing when at all possible, but make sure the main emphasis is serving the person well. And that makes all the difference. It can change our whole experience of life and certainly inform our endings. Ira Byock again dials into this conversation. He said, the sobering fact is that there are worse things than having someone you love die. And he's alluding to the fact that many of these interventions that can be life-sustaining, the suffering escalates to such an extreme that the quality of life is non-existent. And that is difficult to experience. It is also very difficult to witness as a family member and friend. So let's consider the following reflections and sometimes critiques of our healthcare system today. And these are not my personal opinions. I'm sharing with you the insights from medical professionals in the trenches day in and day out, highly revered, highly respected doctors. And all of these resources are noted in the handout that is associated with the presentation today. So let's consider the voice of Jessica Zitter, and maybe you've heard of her. She has written a book many years ago entitled Extreme Measures. She also has a PBS documentary, Extremis. Now, she is a board-certified palliative care doc. She's also a pulmonologist, so she understands the acute care model and the palliative approach intimately. And she reflects on her experience of being trained to be a doctor. And she said, while I gained vast technological knowledge during my training, my spirit, the compassion and humanity I brought with me to medical school in Cleveland, it began to atrophy. It started to wither. And she said, I went into medical school a human being, and I came out a doctor. And she's very upfront and honest. She said for many years working in the ICU, she was focused on treating the disease, and she lost sight of the human being. Dr. Volandes, who also works out of Harvard, he's a researcher, and he focuses on healthcare issues. In his wonderful book, The Conversation, he echoes her sentiments. He said, modern medicine can be and oftentimes is dehumanizing. And we need to be aware of that so that we don't take it. We demand more, actually. We are well-informed consumers of healthcare, and we know that we deserve better. I want to be seen and heard as a human being, and I want care, not just treatment. Now, we also saw this tendency exacerbated in the 1970s. Before that time, ICUs were few and far between. But starting in the 70s, they were very commonplace. So we know that environment, it's very sterile, a lot of machines, not a beeps and whistles, and it is a time when people need some elevated levels of care. And I'm glad we have them. But sometimes they're overutilized. And when we have a strength and we overutilize it, it can become a weakness. Again, Zitter comments on the prevalence of ICUs in her formative years as a doctor. She said, our infatuation with the ICU and its machines caused us to use them indiscriminately. She said they became the end all and the be all, the go-to, the norm each and every day. And she even revealed that I never even considered that a dying patient might choose comfort as his or her priority. She never thought that someone would say no to a life-sustaining intervention because she was focused on quantity of life, not quality of life. Her perspective has changed dramatically over the years. Now, this is a reflection from Dr. Volandes again, who says that Americans receive some of the best healthcare money can buy. They also experience some of the worst deaths in the developed world because seemingly we don't recognize when the end is near, and we just keep pushing that limit, requesting or receiving advice that we should be more aggressive in our care, and not recognizing the flip side of that, which is enhanced suffering because of those interventions. Atul Gawande also is a wonderful voice that can educate us about our healthcare systems today. He is a surgeon. He wrote the book Being Mortal, which if you have not read this, I highly recommend it as well. And he's also a contributor to the New Yorker periodically. But he's companioned many a patient and family. And he said, it's not death that the very old tell me they fear. It is what happens short of death. They fear the nature, the experience of the exit. And perhaps you resonate with that fear. Now, we are so fearful, it's reflected in how we spend our money related to healthcare. Contemplate this data point. 50% of all Medicare expenditures occur in the last 6 months of life. And what we will learn here in short order is that when we request or when we are prescribed some of these more aggressive interventions at the end of life, they're very expensive. But the odds that they will be beneficial, that they will enhance the quality of our life or even extend our life significantly, the odds are slim to none. And we, as part of our creative team on this plan of care and goals of care, we need to know that so we can make more informed choices. So this is kind of the caveat here. Blind trust in the system, I think, is ill-advised. And that's true for any process we're in making a decision. This is our life. It's our responsibility to gather the information to make informed choices. But blind trust in our healthcare system today, even blind trust in your physician, that can lead you down a path that doesn't align with what you value the most. And mix in the following fact. Doctors consistently overestimate how their patients will do, how long they will survive, and how well they will recover. Now, this is borne out by longitudinal studies as well. When I was working in hospice, we were weaned on the fact that doctors typically overestimate the time someone has to live by 3 to 5 times. And that's critical for the admission into hospice. A prognosis of 6 months or less is mandatory. Well, when we had a patient admitted into hospice, we recognized the odds were they probably had 6 to 8 weeks. So we would encourage family members to say what they needed to say, to do what they wanted to do, and to do it right now, because they were not going to be guaranteed that 6-month period of time. So according to the experts in the field, whether it's Bioc or Volandis or Zitter, patients and families today are poorly supported and ill-informed about the various options that are presented to them. And in general, our healthcare system doesn't do a good job of helping people deal with the burden of illness. And remember, a lot of that burden of care, the healthcare system has offloaded to the family because they don't have the staff, nor do they have the finances to offer that level of care to patients. So today, complacency doesn't serve us well. And if you sit back and relax and you think, well, I'm just going to trust the process, again, your wishes will probably not be your reality at the end of life. So we need to age with our eyes wide open. We need to understand this experience of aging, the complicating factors of a chronic disease, and the reality of our healthcare system today. And we also need to expect that the unexpected will happen to each and every one of us. And when it does, then thoughtfully respond. Don't have a knee-jerk reaction, but sit back and contemplate the resources that you have in hand. What will serve you best? So your response is going to be rooted in your specific, unique priorities. And realize that your priorities may change as your medical situation changes. So a choice that you make immediately after your diagnosis, it can evolve and usually does over time. So the tendency is once we recognize that something's going on with our health, we want to be more aggressive. We want to see if there's a possibility of cure. And then perhaps when we recognize that's not possible, we're going to pull back a little bit so we can have a higher quality of life with less aggressive interventions. The meaning or interpretation of best care possible may well change and usually does over time. So I think we have all experienced and we know intuitively life can turn on a dime. And that may be related to a significant diagnosis, or it could be some other life changes that will potentially affect your ending. So it could affect your support system, where you live and how you live. So be attentive to the fact that if the death of a life partner occurs for you, now the future looks very different. That was your naturally occurring support system. Now, who will you rely upon when you have a change in health? What about a major life transition? For example, retirement. That is a big change that we all contemplate. It changes the nature of our existence, as does a relocation. If we move from a home and a community that we've been part of for 30 years, again, where do I belong? Who do I hang out with? Who knows me? Who do I trust? Who would be there if I called them to care? And then the big one is a change in our own personal health, whether that's physiologically or cognitively. All of these life changes associated with aging, it has a ripple effect, and it definitely can affect our sense of purpose and meaning and our reason to be. And if we have a change that results in a consideration of who am I and why am I here and what I'm about, if we start to believe we have no reason to get up and out of bed every day, then our will to live starts to wane. And that is when people become hopeless and helpless. And I am a firm believer that hope is mandatory if we are to keep going. So recognize that all of these changes related to aging and a change in health can have a profound impact on who you are, how you are, and perhaps how you choose to end this existence. So a reason to be, meaning is critically important for human beings. And if we feel as if we serve no significant purpose in life, it affects our mental health, our emotional health. Just another consideration in this gap time. Certainly a change in health, whether it's for yourself or a family member, it has financial implications. And we all have limitations. We don't have an endless stream of revenue coming in. And so we may think, well, I can access some services, but maybe not all the services that I need. We have to be realistic about that. Another complicating factor in the gap time is social isolation. I'm sure you've heard and read a lot about chronic loneliness of late and the implications that has on the quality as well as the quantity of life. And many of the changes we've just highlighted related to aging increase the risk of becoming socially isolated, whether it's the death of your partner, of move away from your community. And the big kicker on this social isolation as we get older is that we all need a support system. We will all require care at some point in time. So who will you turn to? It has dramatic implications on how your life will end. And then there is the unexpected. The unexpected things that we could add to this list, they assume many different guises. And depending on our own particular circumstances, the situation we are challenged with medically, our support system, our attitudes, our beliefs, our religious traditions, some are more challenging than others. So just know, even with the best laid plans, something is going to rise up and surprise you. And in that moment, you take a deep breath. You have self-confidence and belief. You realize you've bounced back from other adversities and you can handle this as well. Now, I want to look specifically at some medical turning points that are typically encountered very late in the lived experience in the latter part of life. And these are the moments, more often than not, that can totally derail your ending. And again, I'm not offering you advice. I am not a medical professional, so I'm not giving you medical advice. But I'm sharing with you insights from some medical professionals. And I'm encouraging you, if you have questions, to talk to your own doctors and gather the information you need to make important choices related to your health and to your ending. Because an ill-informed choice, oftentimes years before you die, maybe months before you die, can totally derail your plans, and you have no clue that this is a possibility. If we make a poor choice, it leads to what Jessica Zitter refers to as the healthcare conveyor belt. And she describes this in her book, Extreme Measures. And she, as a doctor, has seen this far too many times, and it's heartbreaking for her. She said, in the midst of a crisis, oftentimes, or just a very poignant scenario when people are raw and ragged and emotional, they make a decision where the patient lands on this imaginary conveyor belt and it's moving in a direction that is juxtaposed to what they always profess to want. And this conveyor belt typically moves the patient toward a higher acuity of care that will be required if not mandated. And they have no idea that it's happening until they land in the ICU or they are told they can't go home and they need to transition into a long-term acute care setting. And that's when we look around as the patient and say, how did I get here? I did everything I could to stay as healthy as possible. I don't want to conclude my journey in this sterile, impersonal environment. So I want to highlight 4 major turning points that oftentimes arise at the end of life. And again, I'm not saying you should do this or you shouldn't, but you should have the information, the data, and the accurate assessment from your doctor about the blessings and the burdens, the pros and the cons, the risk and the rewards of each of these in the context of end of life. So let's consider the pros and cons of breathing machines. This oftentimes arises. So let's look at just a simple scenario. Let's say that you're 85 years of age, you have a couple of chronic conditions, so that's compromised your physical wellness, and you've also developed a respiratory infection, and you thought it was going to go away until Sunday night at 11 p.m., always happens on the weekends, late at night, right? You are really struggling to breathe. And so you decide, I need to go to the emergency department. So you go there, you're assessed, the tests are run, and it's determined you have a pretty significant pneumonia. And the doctor is concerned because you do have 2 other chronic conditions and your age is 85. And he says, I want you to be admitted into the hospital and you are just exhausted trying to breathe. So I recommend a temporary breathing tube. Now, in that moment, when you're a bit frenzied and your family is concerned about you, you're thinking, okay, it's temporary and I need to be able to breathe to live. So more than likely, you're going to say yes. And you may not recognize that the clock just started ticking. Time is critical in this situation. And most doctors will only allow a patient to have that breathing tube for 2 weeks at max, because beyond that, they're afraid of damaging the trachea. So knowing that, let's say in this little scenario we're talking about, you're in the hospital and you're non-responsive to the antibiotics. You're not getting better. So the doctor comes in, talks to you and your family and says, we need to change the drug protocol. We're going to try a different antibiotic. But in the meantime, we still need to help you with your breathing. We're going to put you on a ventilator because we can't leave that breathing tube in. Again, you're hearing breathing, you want to live, and more than likely you might say yes. You'll agree to that. Just know that in the latter part of life, when we are compromised by other disease processes, we may be suffering the frailties of aging, and we've also become weakened by being bedbound in this moment. The odds of ever getting off that ventilator are not in your favor. And the other thing we need to recognize is that it's almost impossible to die at home once we're plugged in. This is a reflection, again, from a doctor, from Jessica Zitter. And so if your preference for your ending is to be at home surrounded by your family, your friends, your pets, your pillows, and your blankets in your bed, if you make this choice to go on the ventilator, you may have precluded that possibility. It will not happen. because most families cannot manage a vent in the home. It requires specialized clinical care. So, again, I'm not saying you should do this or you shouldn't, but you need to know the implications of the choices that you're making. Because ill advised, you can have a very different ending unfold, something you never imagined, something you don't want. Now, another very common question that comes up is at some point in time, well, would we contemplate artificial nutrition and hydration when we're no longer able to swallow? This is a question that presents itself as, let's say, Alzheimer's disease progresses, maybe ALS, a variety of other neurological conditions. Well, how do we achieve being fed and watered at that point in time? Well, artificial nutrition and hydration is provided intravenously or via feeding tubes. And this is a very emotional decision for all concerned because we show love by eating together, by drinking together, right? And we can't imagine withholding those things from people that we love. Thinking about someone being hungry or thirsty, that just seems cruel. Again, this is where knowledge is power. To recognize that as we approach the end of life, and remember, we're talking about in the context of end of life care. The biology of the body, it works in this way. We start to shut down gradually. It doesn't just stop instantaneously. But over a period of time, we're not able to process nutrients in the same way, and we don't hunger in the same way. And it becomes more difficult to void fluids, and we don't thirst. So if we can't void the fluids that are being pumped in, then we start to become very uncomfortable with bloating, and that can compromise the skin, which is an open invitation to infection. So, what we know, again, from research that's been published in the last 10 years, is this process at the end of life dramatically enhances suffering, and it complicates the dying process tremendously. It is also proven that it does not prolong life. And if that is your goal for this, that goal is not attainable through this intervention. Again, I'm not saying you should or shouldn't, but you need to have the information to make an informed choice so you can have an ending of your own choosing. Then there's the issue of cardiopulmonary resuscitation, CPR. If you were to go into cardiac arrest, would you want to be resuscitated? Well, to make an informed choice, understand the odds. For someone in the latter part of life approaching death, the odds that you would be successfully resuscitated are less than 3%. This is not the scenario that's portrayed on TV in Grey's Anatomy, ER, Chicago Hope, whatever television station you choose to watch. This is less than 3%, but it's guaranteed that it will be a brutalizing process for an older adult, oftentimes resulting in cracked ribs or a cracked sternum. And if resuscitated, you would more than likely then be placed on a ventilator. So you need to know that in order to make an informed choice. Does this align with your priorities and your values and your goals, or does it not? And then you can determine yes or no. But according to Zitter, CPR is often of no benefit for many of the patients upon whom we use it. And then there's dialysis. For those who have total renal failure, maybe that's a consequence of a progression of diabetes, or maybe it's medications that you've taken, maybe chemotherapies that have damaged your kidneys. This is a dramatic change in your lifestyle because you will visit a dialysis center 3 times a week. That usually takes 4 to 6 hours. Now, there are new guidelines, and you need to be aware of this. Again, evidence-based research has concluded that after the age of 75, this is not a viable intervention. It is not a long-term fix for renal failure because we respond differently to dialysis at an advanced age, and it becomes very arduous. So again, understand the likelihood that this could help you because going to dialysis, your daily rhythm is totally disrupted and the quality of your life drops dramatically. The side effects for dialysis can include lower blood pressure, which leads to nausea, kind of feeling woozy, there's instability, so there's a higher risk of falling. So those are the big four that many doctors talk about that can be a turning point and can totally derail your plans for end of life. So I highly recommend reading Jessica Zitter's book as well as Angelo Volanzi's. Now, there's some other unexpected complications that can derail your plans, and we're just going to touch on a few of these. Certainly, as we get older, there is an increased risk of falling. And falling can be the beginning of the end. And I'm sure many of you have heard many a story about this. Recently, I was chatting with a family and they were talking about their mother, who was in her early 90s. And up until she fell, she had lived independently. She was exercising every day. She was vital, vibrant. She was loving her life. And then she fell and broke her hip. So she went to the emergency room, talked to the doctors. They decided to do surgery to repair the hip. From that point, she went to ICU to recover, and that lasted longer than they expected. And then she was discharged to rehab. Well, this took months unfolding. And so once she entered the hospital, she was in an unknown environment. And in ICU, we recognize, regardless of age, it's very destabilizing because you never know what time of day it is. Sometimes you don't even know where you are. People come and go. There are a lot of sights and sounds that are unfamiliar, and people become confused, many suffering from ICU psychosis. And then transitioning to a rehab center, that's a different environment. So by the time she concluded her rehab, she was manifesting signs of dementia, total confusion cognitively. And so she was not allowed to go home. She was discharged to a memory-specific care unit. And it devastated the family and obviously devastated her. So we need to be aware and to do everything we can to stay as healthy as possible for as long as possible. But again, there were choices that were made along the way that ultimately derailed her plans to live alone and to live well and to die in her home. So it was the proverbial tragic domino effect, just one thing after another. I would also like to highlight this particular complicating factor that if you currently have a defibrillator, easy for me to say, right? Implanted, or you're contemplating that, predicated on a cardiac situation, this is a device that sparks your heart back into rhythm. You want to talk to your cardiologist related to your end of life care because at the end of life, you will want to disconnect this particular device to allow a natural death to occur. Otherwise, that device will keep sparking your heart back into beating. And I've heard horror stories from many families that it was something they could not stop. There are some cardiologists that are not willing to disconnect this particular device. They think it's unethical. So work with your cardiologist, find out if they're willing to implant it and then disconnect it at some point in time. And if not, then you need to seek a second opinion. And then also aggressive treatment at the end of life. Is it advisable? Ongoing up until the very end. Well, again, according to Jessica Zitter, in the last 6 months of life, things such as chemotherapy, there are very few benefits, and there is a tremendous amount of burden. It dramatically reduces the quality of life. So make a well-informed decision for yourself and your family related to this particular option. So the undercurrent for all of the things I'm sharing with you is don't be shy. Don't be shy in asking your questions, getting the information that you need so you can make an informed choice that paves a way for a preferred exit plan. Now, as we gather this information, again, according to Sitter, data shows that the more patients actually know, the more information we acquire, the less likely we want our treatments at the end of life, meaning the doctor's treatments, the healthcare system's options. They can do a lot to us and for us, but is that what we want? Is that what I desire? Will that serve my plan well? That's worthy of our time and our consideration. Also consider this insight. I think as we learn more and we become more discerning about the options presented, we actually move toward what doctors want for themselves. Zitter notes this: while we, the doctors, continue to provide life at all cost care to others, we doctors become more committed to avoiding this outcome for ourselves. So, what's good for the goose, good for the gander kind of scenario. Now, I have many friends as well as colleagues that work in the healthcare profession, and I've had this conversation with them, and they are honest with me. When I ask them, well, would you do this? And they're shaking their head going, absolutely not. I would not go there. So I think that insight is something for us to contemplate. We are wise to recognize these potential turning points in our lived experience and how it will affect our plans as far as the conclusion of this journey. Wishful thinking does not serve us well. So be proactive. Have some skin in the game. Lean into this process of planning and gather all the information you need. Ignorance is not bliss when it comes to healthcare. So be an educated consumer. Do your homework and pose the questions that must be answered so that you can feel somewhat confident that your wishes are going to equal your reality. And if you encounter resistance from your healthcare providers, seek a second opinion. Work with someone who takes the time to listen to your goals, to your priorities, and they are focused on you, the person. That is their focal point, not treating a disease. And surround yourself with competent, compassionate, supportive companions, whether it's your clinical team or it's your family and friends. We're going to need all the help we can get as we approach the end of life. Now, if you're listening to me today and you're thinking, well, Jane, this all sounds well and good, but I don't have anybody in my life. I've outlived my peer group. I'm a solo ager. Who am I going to rely on? Well, oftentimes, maybe we need to solicit the help of a professional advocate. So I want to suggest that you contemplate hiring a geriatric care manager to help you navigate the healthcare system. This is a profession that's been around for many years now. There is a national membership called Aging Life Care. Go to their website, aginglifecare.org. You can put in your zip code or the city in which you live, and it will pull up a list of all those professionals who serve in this capacity. Typically, geriatric care managers are trained as nurses or social workers. Some may have an area of expertise, such as dementia-specific care. But you can read their bios. There's a way that you can contact them for a free consultation. You can understand their fee structure. You can understand what services they offer. But this can be a lifeline for you as a solo ager, but it also could be a huge benefit to your family as well. Just another level of support from a knowledgeable professional that understands the complexities of care and the nature of our healthcare system today. So to wrap things up before we address some of your questions or maybe listen to some of your stories, at the end of life, what could possibly go wrong? Well, as I've enumerated, let me count the ways. There are so many moments, so many small and big decisions that can derail our plans. So again, knowledge is power. We need to be proactive. We need to anticipate. We need to develop the questions, identify the concerns, and access those professionals that can offer the valid, reliable information we need so that we can feel confident that we've done the best we can to best get the best care possible, resulting in our preferred ending. So to stay on track, and this is a message again from Dr. Ira Byock, to stay on track and to live into your wishes, be informed, so do your homework, be prepared when working with your clinical team. Don't waste their time. Schedule a consultation, have a list of all the questions, and work your way through that process. Be polite because you don't want to alienate the clinicians you need the most. So go in with a collaborative approach. Help me understand this. Educate me. Serve me well. And then be persistent. Sometimes we have to be that squeaky wheel, and not in an annoying way, but don't allow anyone to just push your concerns to the side. This is important to you. This is your life. So make sure you are seen and you are heard and you are served well. Plan for your preferred ending. It is worth your time. It is worth your investment. It is worth all the energy that's required. Because, my friends, endings matter. So one last comment. I always offer a heartfelt closing. And today, because we covered so much information, it's short and sweet. Plan with the end in mind so that you can live long and live well all the way to the end of the road. May it be so. So just a few life-giving resources. If you are like me, I'm a student from the time I'm born until the time I die. If you want some more information about the whole experience of life, aging, end-of-life care, and caregiving, you can check out my website. I have a lot of events and programs coming up. At cardinallife.com, you can click on the events tab, and these programs are virtual, so it matters not where you live, and they are also free of charge. All are welcome. If you see a program that tickles your fancy, click on the link. It sends me an email, and I will add you to the roster. If you're a fan of reading, I wrote Caregiving for the Genius. In Colorado, most libraries have a copy of this. But if you want a copy for yourself, you can go to Amazon. As we all know, we can buy anything on Amazon. And if you enjoy podcasts, I have Cardinal Musings with Jane Barton. I chat about a myriad of topics, and perhaps this would be a benefit as well. More than anything, I want to thank you for sharing a bit of your journey with me today. And I hope you heard something of benefit, maybe something that you never considered before, and it will prompt you to contemplate, to consider, and maybe even tweak your final plan. But I just hope that you feel today as if your time was well invested with me. So know that I'm wishing you many blessings on your journey, and if I can ever be of benefit to you and yours, don't hesitate to send me an email at cardinallife@msn.com. I would love to continue the conversation with you. And so now the best part of the program for me is to see what questions bubbled up and if we can chat a little bit. So I'm going to stop sharing my screen so I can see your lovely faces, and we'll see what bubbled up in the chat. Pam, did you see any questions I need to address specifically?
There was a question from one of our wonderful participants asking whether a pacemaker is similar to defibrillator at the end of life, and if that would make a difference.
A pacemaker functions in a very different way for a different reason, so it's not as problematic as the defibrillators. Because the ICDs, basically, they continually shock the heart back into pumping, and a pacemaker is just a regulator for those who typically have a slow heart rate. So it's not the same concern.
And also, that same individual also wanted to say a thank you to you because it's not a happy discussion, and your voice was a calming situation for her. She doesn't feel that she will not overwhelm her son with this information. Um, she's also feeling stressed from handling things from her elderly mom, but your voice has calmed her
Oh,
considerably.
well,
That
I'm
was
glad for that because I know I recognize the topics I typically address are oftentimes things we don't want to chat about. And we would rather talk about the Broncos or, something that is inconsequential. But these things, if we can find the courage to confront them collectively, if we feel as if we have other people that are struggling with the same things, if we can confront that fear that oftentimes is paralyzing, and we realize there are some resources that are things we can do, and if we can control the controllables, it's amazing what a relief that is. We feel our anxiety start to go down a little bit, and it frees us to live more intentionally. And I learned that the hard way because my family, we did not talk about any of this stuff when I was caring for my mom. And it inhibited my ability to evolve as an adult. I was scared to death of death. And that is not a way to live. So if we find the courage to confront our fears, then we're free to live in a more life-giving way.
all right. Also, we have a question from Tracy. She said, I've completed advanced directives. Most forms have a will yet. I've heard of all of this pre-planning and can't still. Is it enough? Do you have any advice regarding more forms that should be looked at?
Well, I think with advanced directives, it's important to recognize it's just not a one and done process. So, based on how your journey unfolds and changes in your medical conditions, it's an iterative process that needs to be revisited because our preferences may change over time, and they usually do. But with advanced directives, the critical form, there isn't just a form, it's a compilation of forms. So I think the biggie is having a medical durable power of attorney. So you designate your surrogate decision maker. Some people will opt to have a living will, and that's specific if you have a terminal condition. Two doctors agree to that. And then it's very specific about life-sustaining treatments. Do you want them or not? You can also include or maybe just do the one-stop shop with the 5 Wishes booklet. It's very comprehensive. It serves in a variety of different capacities. And there's another form that you may not be familiar with. It's called the MOST form in Colorado. This is really not an advanced directive. It's a doctor's order. And MOST stands for Medical Order for Scope of Treatment. And this is appropriate for anyone who has a serious illness, is compromised by that, or is at a very advanced age. And these individuals may be bouncing from residence to the emergency room periodically for management of pain and symptoms. And what we learned many years ago is that oftentimes in that transition to acute care and then back home, our wishes got lost in the shuffle because most people don't carry their advanced directives on their person. But this doctor's order, it becomes part of your medical chart. And each state has a particular color and form that becomes part of that chart. And it's usually a neon yellow, neon green. It jumps out of the chart. So if you're in the emergency room, the doctor can't miss it. And it will tell them whether You whether want to be resuscitated? Do you want antibiotics? Do you want a feeding tube? So again, it's a very limited scope, but it can ensure that your wishes are going to be honored related to your medical care. And then many folks are doing dementia directives. They're adding that into their advanced directive file of documents, and you can access that form online.
Tracy also asks, any advice on how to broach this topic with resistant elderly parents? Mhm.
Wow, that is a difficult barrier to overcome. And I just came back from a conference in Baltimore related to aging and talked to a lot of professionals that are experts in the field. And we recognize that resistance can come on either side of that relationship. Sometimes the older parents don't want to go there with their kids because they feel like their children are forcing them to do it, reversing the role, telling them what to do. And then sometimes the adult children don't want to go there because they don't want to contemplate that their parents at some point in time will die. So sometimes you just have to be a little bit creative and maybe present it in a different way. Instead of, this is a legal document, we have to contemplate death, we have to make sure all our affairs in order. Sometimes just changing your first invitation can make all the difference, and say, hey, can we sit down and talk about how I want to live until the very last moment? And I need your help in achieving my goals. I want you to help me have a great quality of life. I'm counting on you to help me. That's very different than saying, hey, let's talk about what's going to happen when I die. We live in a society that is age denying and death averse. We're scared to death of death. So you have to use different language that's a little bit softer, but gets you to the same discussion. You might also want to check out, there's a group called the Conversation Project online, and they actually have a PDF document that gives you ideas on how to introduce this subject to your family in a less daunting way so that their defenses don't just pop up. But the Conversation Project has a lot of good starting statements and questions to kind of get the ball rolling.
And
Now,
we have a question from Diane. She recently moved to Colorado, and she asked if Colorado has any end-of-life laws that help or impede final wishes.
Well, in Colorado, we did legalize medical aid in dying. Now, I don't know if that's what she's alluding to, but that is a process, actually a program, then you can request to enroll in when you are deemed to have less than 6 months to live. And medical aid in dying means that you would work with a doctor who would prescribe a lethal dose of medication, and the goal is death. And then the patient would have that medication filled, and then it must be self-administered. That is the definition of medical aid in dying, where euthanasia, which is not legal in the United States, is the doctor administers that dose. But we are one of 12 states now in the country that has legalized that particular mandate. So that is a choice that's not available to everybody in the country, and an important choice for many people. And so once you establish residence, you have that terminal diagnosis with a prognosis of 6 months or less, then you can start that enrollment process.
Okay, good. And what are your thoughts on assisted suicide?
What are my thoughts on it? Well, first and foremost, I would not call it assisted suicide.
yeah.
That is a very volatile, very triggering term, and a choice for medical aid in dying. The motivation is very different than someone who chooses to complete suicide for a mental health concern. So that distinction, some people may think that's a nuanced, distinguishing term, but it's really important.
Mhm.
But medical aid in dying, I think it's obviously a very personal choice predicated on personal beliefs, your circumstances as far as your disease process. But I think I am in favor of choice. I align very much with a bioethicist out of the University of Utah, Margaret Batton, Battin. She has written extensively about the various choices around end of life. And she is a proponent of choice, as is Timothy Quill, another bioethicist. So if you're interested in diving more intentionally into this subject, they are good, vetted resources for you. But I know for my own self, I want to have a choice. And this is predicated not only on my profession and the knowledge I've acquired over the years, but it's my personal experience of companioning my mom and my dad and my brother and my godmother to the end of their journey. And those were not always pleasant experiences. They suffered tremendously. And it's hard for me to find any rationale where I can justify some of those experiences. So, as is the result of many a research project, not everyone who enrolls for medical aid in dying actually implements the process. They don't take the drug, but they want to have that option. They want to have some sense of control
Right.
that if it gets to the point they just can't stand it anymore, they have an exit. They have a way out, and they have the ability to choose that.
Mhm.
The other thing, just one thing that popped into my mind that we need to keep in mind, this is not an option in our country for those who have dementia. Because in order to enroll in the process, you must be deemed competent.
Right.
And by the time you have less than 6 months to live with dementia, you are not competent. So it is not an option.
Okay.
Anything else that's popping up?
It looks like
That's
Esther
it.
might want to get off of mute. No? Okay, never mind. I see her screen.
Okay, let's get her.
Yeah, you have the ability to unmute yourself, Esther.
Okay. Esther. Oh, Esther. Oh, she wants to talk.
Yes, I got
There
it.
you go.
I'm
Hey,
having trouble.
hey, Esther, how are you? It's good
Hi.
to see you.
I'm right now. I'm good. That's my new response. Right
Yeah.
now, could be worse, could be better. But anyway, two things. One, as usual, I must say, there is no one like you that I know of. And I forget in between your talks that I need to be more active with the resources you provide. I mean, I listed all these doctors and things, and will I get to it? I hope so. Okay. I'm being honest about that. I wanted to ask you, I know there's some people who have all these directives like I do, and I'm starting to post them as soon as you walk into my home so that there's no question about where it is. I've heard about docs and ambulance that come and they just start resuscitating because they don't see anything, and that's their go-to. Or maybe you're out in a restaurant or wherever you might be. Is there something you know of that can condense? I think some concierge docs have something. Like a little Bible scroll that he wears a necklace or a bracelet or something so that, hey, it's right here, the directives. Do you have any sources about that?
I don't. And in fact, that question came up when I was at this conference and I was talking to a woman who's an expert on solo agers. And she said when she travels, she always carries a copy of all of her directives. So they're 8.5 by 11, which is kind
Oh,
of cumbersome.
yeah.
But she has a folder that she carries with her all the time. And another important thing I want to highlight from your comment is there's another form many people choose to fill out. That's the CPR directive that indicates in your home, this is for a residential setting. If you were to have a medical emergency and somebody called 911, that directive will indicate to EMTs, this person does not want to be resuscitated, but it has to be posted in a particular place because they don't have time to look through your whole house.
Sure. Yeah.
And usually usually they'll ask that you place it on the front of your refrigerator. Sometimes it's behind your front door, but if you're not sure, to verify that, just call your local firehouse, the one closest to where you reside, and say, where do you look when you come into a house? And then you can rest assured when they walk in, they'll check. If they see it, they will abide by it. If they don't, they legally must try to resuscitate you.
That's what I've heard.
Mhm.
Okay. Thank you.
Thanks for the comment and question. Always good to see you, Esther.
Same here. Thank you.
Jane, I just wanted to add, on the section on dialysis, there is an option of peritoneal dialysis, which can be done at home. Andy
Right.
comment about that in the chat. So that's another viable option for if you have renal failure.
Mhm.
That is a good option for some folks.
Not-
But sometimes it's much more convenient because you can do it in your home sometimes while you're sleeping. As we get older, if we are compromised in other ways, there is a tremendous need to do this in a clean environment.
Yeah.
And so you have to be able to manage the equipment and to control your environment. That means you have to manage your pets if you have any pets in your home. And so it can be a process that can be overwhelming for some people. But whether you do it in your home with peritoneal or you do it in a dialysis center, the effectiveness of it still is lacking after the age of 75.
One more thing.
Thank you.
Mm-hmm.
Me?
Mhm.
Go ahead, Esther.
Okay, one more thing.
Uh-huh.
Always one more thing. Husband says. Back to the dementia. And you say all bets are off if you have dementia. And my mother had it for 15 years. My husband now with Parkinson's is starting to have it. We have power of medical attorney and the other one, power of attorney. But as far as end of life, I remember the movie Still Alice. Oh my gosh, that was quite impacting at the end. She tried to help herself and spilled it. I don't know if you saw it. But anyway, at what point can those of us who end up with dementia have end of life check out? If you're in a nursing home, it's really tough. At a facility, even at home. I mean, I have no idea where I'm going to be, but I worry about that because of my mom and because of my son. Just being a solo ager, other than my husband, who's I'm taking care of.
Yeah, the whole scenario of dementia is problematic for so many different reasons, but certainly about being able to access choice at the end of life. And in the United States currently, that is not going to be an option to enroll in medical aid in dying. But the 12 states that have actually legalized this, there are now people that are petitioning to edit that statute, to change it in some way. And there are a variety of different approaches. But also know there are some people, and there is a book called In Love by Amy Bloom. She's a novelist typically. But in this memoir, she talks about how her husband was diagnosed with early onset Alzheimer's. I think he was in his early 60s. And they sat down and talked about that diagnosis. And he basically said, I'm not doing this. I'm not living this. And they recognized he didn't have an option in the United States. And while he was still competent, he enrolled in a program in Switzerland through Dignitas. And in Switzerland, they don't have the requirement of you must have a prognosis of less than 6 months to live. So he was able, and they had the financial ability to enroll, to pay for this service, and he ended his life in Switzerland. But that program still requires competence, which means he had to make that choice early on in his journey of dementia. And I've heard of several people that have opted to do that of late.
You gotta get a lot of help to have you get there and all that. I mean, even if you have the means, it's the, thank you. Well, last thing about that petition, how
Mhm.
can somebody learn about that? Do you know where we go to for that?
I would probably check on the website of Compassion and Choices. That is a lobbyist group, and they present a lot of materials related to end-of-life choices. And they may have the latest and greatest as far as governmental activities, because they are knee-deep in the trenches of trying to advocate for choice at the end of life.
Is it .com.org or just Google it and it'll come up?
Just Google it and it will come up. I can never remember.
Okay,
Be honest.
you got enough going. You remember that's pretty darn. Thank you again.
Uh-huh.
And I'm sorry, Ron, go ahead.
Just an FYI to the group, Diane stated that Amazon does sell do not resuscitate bracelets.
Oh,
So that's another option for you if you're not at home and you have a medical issue. Then if you were wearing that, they would know not to resuscitate.
that's good.
I noticed there's a question about all the resources that I mentioned. There is a handout for this program. And Jessica, you might want to repost it because sometimes when people arrive late, it doesn't show up on their chat stream.
Thank you, Jane. I've put it in a few times. I'll do it again right now. And you'll all get it in your email tomorrow with a thank you for attending. And we do have a survey. We'd love your feedback so that we can keep Jane coming back for more.
I'd love to do that. This is my delight.
Well, we are over time. Thank you so much to everyone for staying on and chatting with us. And thank you, Jane, for being here, Alan and Pam for leading everything. We appreciate everybody.
Blessings, everyone.
Thank you. Thank you.